our colleague Majid Al-Ghamdi. He will talk in representing the scientific committee for this SARO rounds. He will give us the general format and the future of this rounds in like 1 minute, and then we'll start the scientific activity. Majid, you can start.
Thank you, Prof. Thank you very much. Assalamu alaikum wa rahmatullah jami'an. Welcome into this lecture and SARO lectures. We called it SARO rounds, which is basically an idea that we had a long time ago, and lately we started working on it on behalf of the SARO. So basically, I'm not going to share my screen, probably I'm not allowed to, but I just want to give you an idea about what is the SARO rounds and what are the committee members. So basically, we are 5 members who were selected by the scientific committee or agreed upon by the scientific committee, and then we met virtually and we discussed a few things, and we came up with a format for these type of series of lectures. So I just heard that you're interested to know who are the people in this small group. We have Dr. Majid Al-Uthman, Dr. Zaid Justiniya, Hussam Al-Assaf, and Dr. Tagheed Al-Hindi, and myself. So, so the purpose, as you would expect, is just to gather so that we update ourselves on a few important subjects in radiation oncology. And we noticed that many other groups in Saudi Arabia, especially during the pandemic, they started doing more and more of online webinars, and we were kind of behind in that aspect. So, so now SARO kind of was motivated to move that forward, to move forward with the webinars. So basically, it's going to be a series of lectures every month. So we agreed on Wednesday of each calendar month. And by the way, all of these, the format and all of these things that we started with can be changed in the future. So it's subject of discussion in the future among all the radiation oncologists. So it's not this group is just task force that we want to facilitate things and move quickly as much as possible. But of course, we welcome all the suggestions, and we are very dynamic, and we want to embrace all of the things that you may have in your mind. So, so basically, it's going to be 1 hour every month, first Wednesday of every month at starting at 8 to 9. The first topic was kind of selected because of there was an event that already happened a few weeks ago, and Dr. Tagheed Al-Hindi presented this talk there. So we wanted to start with a kind of pre-made talk in that regard. But the future topics, of course, we welcome any ideas, and we will be posting some ideas for in the group for all radiation oncologists, in case we have any vision or ideas for topics and presenters and moderators. I'm not going to actually delay you more, and I would like to hand the microphone back to Prof. Yasser Bahadur to start our program today. Thank you very much.
Thank you, Majid, and inshallah, I wish you all the success for SARO rounds. When I hear the topic of today, it reminds me back during our residency, and maybe my colleagues in the late 90s. The era was hyperfractionation. لما نقول الموضة كانت hyperfractionation at that time. Every couple of months we have a new article where you give more than 1 fraction a day, but you increase the total dose. It was in the head and neck, in the lung, in many other sites, brain, GBM. And then, and it was a big no to give large dose per fraction because of the late side effect. Now it seems with the improving technology of radiation therapy, MRT, SBRT, and so on, and our ability to confine the radiation and protect the normal tissue, the wave now and the trend to hypofractionation. You see it in the rectum, you see it in the prostate, and so on. Dear colleagues, I would like to introduce my colleague Hanadi Habibullah. I'm sure you all know Hanadi. She's a consultant radiation oncologist at King Faisal Specialist Hospital in Jeddah. Hanadi, she was graduated from King Abdulaziz University in the medical school, and she had her residency training in McGill, Montreal, and she did a fellowship in breast and gynae, and then she's back leading the women radiation oncology group in the King Faisal Jeddah. In addition to being a very skillful radiation oncologist, Hanadi, she has very much interest in the quality. She is leading the quality team in our department. Hanadi, she will talk about breast fractionation and especially the highlight on this FAST-FORWARD trial. Hanadi, the microphone is yours.
Thank you, Prof. Yasser. Thank you for presenting me. Assalamu alaikum. And good evening, everyone. Thank you for attending. And I would like to thank the SARO Journal Club Committee for arranging this talk. I will present again, actually, this article. I did already 3 weeks ago, but it was in Saudi Oncology Society. And at that time, it was like a bit busy. We had no time to discuss it deeply and from other radiation oncologists. So we prefer just to present it again in SARO. So we'll have more room to share experience and hear some comments and advices from each other. So I will try to present it in 20 minutes, and after that we'll have room for discussion and interaction. So let's start. For FAST-FORWARD is a multi-center, non-blinded, phase 3 randomized non-inferiority trial. It was done at 97 hospitals in the UK, testing the safety and efficacy of 5 daily fraction schedules of adjuvant radiation compared with the standard 15 fraction 3-week schedule. 4 sub-studies were published and some of them not published yet, including the acute toxicity study and photographic assessment of late side effects, patient-reported outcomes, and local regional radiation, which is not reported because the data is still immature. Regarding the inclusion criteria of FAST-FORWARD, any women or men aged at least 18 years with invasive carcinoma of breast, pathological stage from T1 to T3, for lymph nodes pathologically N0 to N1, and no metastasis. All patients underwent complete microscopic excision of the primary tumor by either breast conservative surgery or mastectomy. Immediate reconstruction was allowed, and all patients had axillary surgery, either sentinel lymph node biopsy or axillary lymph node dissection. Nodal radiation was not allowed in the main study, and concurrent endocrine therapy or trastuzumab or both were permitted. Regarding the exclusion criteria, all patients with the lowest risk and low risk prognostic factors were excluded, and the aim was to increase the overall primary event rate. Any patient with ipsilateral microinvasive disease and or non-gradable tumors, patient with history of malignancy, including contralateral and or previous ipsilateral breast cancer or DCIS. Concurrent cytotoxic chemotherapy was not permitted, and residual microscopic nodal disease, any positive level 4 superior supraclavicular lymph nodes, and any requirement for internal memory chain was not allowed. There is some screen now. I'm not sure what is it. Hussam, I'm still sharing my screen?
Yes, you are.
Yes.
Sorry. Between November 2011 and June 2014, 4,110 patients were enrolled in the FAST-FORWARD trial. Patients were randomly assigned to receive either the control arm, 40 gray and 15 fractions, or 27 gray and 5 fractions, or the third arm was 26 gray and 5 fractions. A sequential tumor bed boost to the conserved breast was allowed, with the centers required to specify boost intention and dose. The dose for breast boost was ranged from 10 gray to 16 gray, and the compliance with allocated treatment was 99%. 5-year visit forms were available for 96% of patients. From protocol version 5, it showed that in 2017, randomization to the test group 27 gray and 5 fraction was closed to recruitment, and patients are allocated to one of the following group, either the control one 40 gray and 15 or the test group 26 and 5 fractions. Patient characteristic, demographic and clinical characteristic at baseline were well balanced between groups. Patient age, the majority were older than 40 and less than 2% in each arm were younger than 40. Immediate reconstruction was done in less than 0.8% of the patients. Majority, around 85% had sentinel lymph node biopsy and 15% had axillary lymph node dissection. For positive lymph nodes, 18% had N1, but local regional recurrence was not allowed in the main study. Majority had T1 to T2, about 98%. ER positive around 90% of the patient, and PR positive 70%, HER2 positive 10%, 80% had negative lymphovascular invasion, and 3.5% received neoadjuvant chemotherapy. 25% had adjuvant chemotherapy, and 95% received hormonal therapy. Boost was given to the quarter of the patients, and the most common dose was used 10 gray and 5 fractions. Stratification and masking. Stratification was by radiotherapy center and risk group. Stratified two main groups, either high versus low. High if the patient age younger than 50 or disease grade 3. Low if the patient aged 50 or older, and grade 1 or 2. Treatment allocation was not masked to clinicians or patients due to the nature of intervention. The study showed specifically the radiotherapy volumes. If the patient had lumpectomy, the CTV will be the entire breast tissue, was either established from field-based tangential fields, or the volume was contoured prospectively. Post-mastectomy, the chest wall CTV included the post-surgical skin flaps and underlying soft tissue up to the deep fascia, and in both excluded the underlying muscle and rib cage. Regarding the PTV dose distribution, prescription dose more than 95% should receive 95% of prescribed dose. And it showed the upper and lower limits as well for the dose distribution. The organ at risk dose constraints was given for the ipsilateral lung volume and for the heart. The V8 gray should be less than 15% for the ipsilateral lung, and V1.5 gray less than 30% for the heart. Assessment. Assessment was done through 3 modalities: clinician, patient-reported outcome, and photographic. Regarding the clinician assessment, patients were assessed by clinicians for ipsilateral breast tumor recurrence and late normal tissue effect at annual follow-up visit, starting 12 months after trial entry. The late onset of normal tissue side effects in ipsilateral breast or chest wall, including breast distortion, shrinkage, induration, and telangiectasia, and breast or chest wall edema and discomfort, all were graded and using 4-point scale from none to very much. Any symptomatic rib fracture, lung fibrosis, ischemic heart disease were also recorded. and clinical assessment of acute toxicity have been previously reported. Regarding the patient-reported outcome, in the patient-reported outcomes sub-study, the questionnaires were administered at baseline before randomization and at 3, 6, 12, 24, and 60 months after treatment, including and using the ERTC quality of life questionnaire module and body image scale and protocol-specific questionnaire related to any changes to the affected breast after treatment. Any change in the breast, in the skin, was reported as well, and scale using 4-point scales, not at all, a little, quite a bit, and very much. For photographic sub-study, photographs were taken at baseline and then at 2 and 5 years after radiation. Change in photographic breast appearance compared with the baseline was scored on a 3-point scale, none, mild, and marked, based on changes in the breast size, breast shape, relative to the, and comparing to the contralateral breast. Patients were ineligible for further photographic assessment if had reconstruction or developed local recurrence. Digital photographs were scored by 3 observers who were masked to patient identity and treatment allocation. Endpoints, the primary endpoint was ipsilateral breast tumor relapse, defined as invasive carcinoma or ductal carcinoma in situ. The key secondary endpoints were late normal tissue effect assessed by clinicians, patients, and from photographs, and other disease-related and survival outcomes like local regional relapse, distant metastasis, disease-free survival, and overall survival. Statistical analysis for local control, the target sample size was 4,000 patients, and that balanced between all groups, providing 80% power to exclude an absolute increase of 1.6% in 5-year ipsilateral breast tumor relapse incidence for a 5-fraction schedule, compared with control, assuming a 2% 5-year incidence in the 40 gray group. Regarding the statistical analysis for late effects, 732 patients per group was estimated for the photographic and patient-reported outcome sub-studies to provide 80% power to detect an 8% difference in 5-year prevalence of late normal tissue effects between the 5-fraction schedules. Clinician and patient assessment of late normal tissue effect were analyzed through comparison of prevalence, the moderate or marked effect versus none or mild between group. After a median follow-up of 71.5 months, ipsilateral breast tumor relapse was recorded in 79 patients. Estimated cumulative incidence of ipsilateral breast tumor relapse up to 5 years was 2.1% for 40 gray group and 1.7% for 27 gray group and 1.4% for 26 gray. The absolute differences in ipsilateral relapse versus 40 gray were minus 0.3% for 27 gray group and minus 0.7% for 26 gray. So non-inferiority was proven for both 5-fraction schedules compared with 40 gray and 15 fractions. For all other outcomes, there was no statistical significant difference between all groups. Cardiac-related death was extremely rare, less than 0.7% in 3 arms, with no migration noted for the extremely hypofractionated schedules. Regarding the normal tissue effects and acute skin toxicity have been studied in 2 sub-studies. Results showed very mild skin reaction with the 5-fraction regimen as compared to the standard 15 fractions for both dose schedule, 27 gray and 26 gray. The longitudinal analysis of all annual clinical assessments of normal tissue effect over follow-up showed a significantly increased risk of any moderate or marked effect in the breast or chest wall for 27 gray group. If we compare it with the 40 gray, and in the other hand, there was no significant difference between 26 gray and 40 gray. This pattern was similar for the individual effect of breast distortion, shrinkage, induration, and breast or chest wall edema, with significantly higher risk for 27 gray versus 40, but again, not for 26 gray. Breast shrinkage was the most prevalent, moderate to marked effect at 5 years. Comparing the 2 5-fraction schedule, 26 gray had significantly lower risk of any moderate to marked normal tissue effect, and breast shrinkage was less if we compare it to the 27 gray. Regarding the patient-reported outcome, change in breast appearance had the highest 5-year prevalence. Higher risk of hardness or firmness was noted for 27 gray compared with 40 gray. No different for all other normal tissue effects. From the photographic assessment, 27 gray had a significant increased risk of mild to marked change in the breast appearance versus 40 gray, and 26, one again with no significant difference between the 26 if we compare it to the 40 gray. So the fast forward trial successfully demonstrated non-inferiority of 5-fraction schedules compared with 40 gray and 15 fractions at 5 years follow-up for patients with early breast cancer in terms of ipsilateral breast tumor relapse. Normal tissue effects up to 5 years for 26 gray regimen. So 26 gray showed exactly equal to the 40 gray. The 10-year analysis of ipsilateral breast tumor relapse and normal tissue effects reported by earlier Canadian and UK trials, like in the other randomized clinical trials which were tested the 40 gray and 15 fractions. And all of these confirmed that although normal tissue effect continue to accumulate beyond 5 years, there is evidence that relative differences between test and control groups change very little over time. And by extrapolation, investigators of the fast-forward trial expect that the relative differences between test and control group will change very little at long-term follow-up, but still to be confirmed. Prognostic groups, the finding of fast-forward trial cannot be applied to different prognostic groups in view of very low overall ipsilateral breast tumor relapse incidence. Dose response for local control, the absence of detectable dose response for local control between 26 and 27 gray per 5 fraction reflects the shallowness of the dose response curve. For subclinical breast cancer, that is around the 98% local control level. But if we look at the curve in terms of late normal tissue effect, the dose response is much steeper, enabling detection of clinically and statistically significant differences in event rates between 26 gray and 27 gray per 5 fractions. Isoeffective dose, the 5-fraction schedule isoeffective with 40 and 15 allows direct estimation of alpha beta for late normal tissue effect, which is consistent with values generated from other trials. The adjusted alpha beta estimate for ipsilateral breast tumor relapse was 3.7 gray. And by the EQD2, the 40 and 15, it's equal to 44.7 gray, 26 gray and 5 fractions equal to 40.6, and 27 and 5 fractions equal to 43.1 gray per, as per EQD2. Dose to organ at risk, it's one of the study limitations, especially for the heart. It's sensitive to the total dose, as we all agree. But the tiny number of cardiac events in the fast forward prevents meaningful analysis. excluding the heart from the treatment volume, I believe as far as possible by using special techniques and deep inspiratory breath hold technique is a priority for any treatment, especially for left side. Regarding the other study limitation, the subgroup analysis, the size of this trial prevents reliable subgroup analysis by the patient age, tumor grade, receptor status, and systemic therapies. But again, consistent with the 10-year analysis of almost 6,000 patients in START trials, which test the 40 gray and 15 fraction, there is no suggestion of heterogeneity. Is this article practice changing? And we keep asking ourselves these questions, and I believe the answer is yes. And we know that many centers, like internationally, they change their practice, especially during this period. The 5 fraction regimen is relevant to both whole breast radiation and accelerated partial breast irradiation. Beyond its safety and effectiveness, the 26 gray schedule is convenient and substantially less expensive for patient and for health services, especially now in the COVID-19 pandemic period. And it is also likely to be safe for patients requiring local regional radiotherapy, but we still need to wait for the result of the sub-study. In conclusion, 5-year ipsilateral breast tumor relapse incidence after a 1-week course of radiation is non-inferior to the standard of care 3-week schedule. The 26 gray dose level is similar to 40 in terms of normal tissue effect, and what that was assessed and seen in the clinician assessment and patient-reported outcome and photographic changes in breast appearance. The consistency of fast-forward results with earlier hypofractionation trials support the adoption of 26 gray and 5 daily fraction as a new standard for women with operable breast cancer requiring adjuvant radiation therapy to the partial or whole breast. Just before I finish my presentation, we always ask ourselves, especially in our institution, what is the criteria that we should follow and to select this patient, and should be select them properly, or we can just follow whatever come from the study. Personally, I ask myself about the age. Should I just choose any patients above 50, or I can go to the younger patient 40 and above, because the majority of the patients in the study were older than 40. Lumpectomy, okay, T1, T2, and 0, grade 1 to 2. What about LVI? 80% had negative LVI. Is that a real prognostic factor and can affect the outcome? ERPR positive, HER2 negative. Maybe there is no big issue regarding the adjuvant treatment, but what about neoadjuvant chemotherapy? Just few patients had neoadjuvant chemotherapy and were randomized in the study. And maybe from here we can open the discussion. Just the last slide that I want to share with you, it's a data collected by Dr. Reem Ajami from King Abdulaziz University, and I would like to thank her for allowing us to share her data. It's a survey was done by her and sent last year to all radiation oncologists in Saudi Arabia to assess their practice in treating breast cancer with radiation therapy. And I just took a screenshot of this table that showed if the dose that we are using for hypofractionation. And as you see, the total number of physicians who replied on this survey, 26 physicians, and the majority are using the hypofractionation, the standard of care 3 weeks regimen, and maybe just one physician chose other. And if you look at the reason why what is the reason that will prevent them from hypofractionate, 11 physicians choose immediate reconstruction. So I believe just from by looking at this slide, we all agree that maybe 50 gray and 25 fraction is no longer, no one is using this fractionation, unless there is a specific and obvious reason. Otherwise, all of us are using the 3 weeks regimen, and maybe soon we will move to use 5 fractions 1 week regimen. Thank you so much.
Okay, thank you so much, Hanadi. It's an excellent presentation. Before I forgot, there is a survey that Hussam submitted. So if just 2 questions, if you can fill it, and he can comment on it at the end of this presentation. Hanadi, I think I really liked your last slide. Breast cancer load, especially adjuvant treatment, representing the main load in the almost half of the patients in any radiotherapy department. So being able to cut the fractionation, being able to cut the fractionation from up 3 weeks to 1 week, it will reduce the load significantly and cut down on the Q. My question to you is, now in real life, like tomorrow when I go to the clinic, I mean, do you prefer, I mean, is there any special recommendation which patient we should go ahead to give this short fractionation? I noted that you are almost wanted to say the low risk kind of patients, so you should not give it to young patient, triple negative, and so on. Is this your recommendation?
To be honest, Prof. Yasser, when I went through the table and all the percentage of patients criteria, the majority, most of the patients, more than 75% had all the good prognostic factors, like older age, but not 50, they choose 40, older than 40, because we used to say 50 and above. T1, T2, just small patients, small number had T3 disease. So basically all what I mentioned here in this slide were from the study itself. But even the LVI, like I never took LVI as alone as a definite prognostic factor. But if you look at the table, 80% of the patient had negative LVI. So should we take all these criteria in account, like when we choose the patients?
But let me ask you, let's ask you in a different way. Now, let's say in the standard fractionation, in the 1525, or in the new standard, which is 1415 or so, we give the same prescription to low risk and high risk. We give the same prescription for luminal A and triple negative, the same prescription. The difference is when you feel there is a higher risk, we give a boost. This is my understanding. So why don't we apply the same principle here? Like we give all the patients 1 week, even the high risk, and for high risk patient, we add a boost. What do you think about this approach?
It makes sense, to be honest. Yeah, to deal with this criteria as we deal with 1415, and we don't make it like difficult. At the end, in 1415, now we move to treat even locally advanced, and we use not to treat inflammatory breast because inflammatory breast was not included in the study, and now we treat even inflammatory breast with 1415, and we don't see any difference. So I believe from this study, it will be the same, but we still need the data to confirm all of that. And I'm not sure, like 5 years, okay, the result is great. By 10 years, I believe the change will not be dramatically different, or there will not be surprises, but should really we wait until we get the 10-year follow-up result, or we can just move on and treat the patient, depends on the criteria that was in the study. And we don't choose just patients with good prognostic factors. We don't have to see any, select them properly. I really want to hear from other audience and radiation oncologists, what they are doing in their institution. And other challenge that we are facing, like most of our patients are locally advanced, and we really don't have patient, just small number of patients, they require just whole breast radiation therapy. And that's, I believe, is another challenge. We'll limit our use of.
So, sure. Okay, so let us hear from our audience. Let's start with Mushabbab. Go ahead, please.
Thank you very much. Really very nice presentation, educational, and thank you very much for SARO for making us active at night. I think this is part of the conspiracy problem that always breast change practice came with logistic problem rather than science. When we have problem with logistic, then we try to escape from longer treatments, and we make the patient happy. Even this studies came at the right time with COVID-19, when everybody liked to treat even single fraction. I have problem with the result, although most of the authors I work with for some time, and when I look to the 27 and 26 grays and 5 fractions, I felt that they should be similar in outcomes, but in the study they are different. If you look just sub-analysis for 27 gray and 5, 26 gray and 5, we should expect that they will be similar, almost similar. But when you look at the result, they are different. There's inherent difference in the study, why it became like this. Second thing, we adopted this. We adopted it badly, even not only adopted, but just we love it because it makes our life easy with the COVID. But the issue here, the study itself, they are highly selective. And in our practice, we are not that selective. Maybe in the centers where they have logistic problem, they adopted the result of 26 and 5 for even more aggressive cancer. And I think this is, we have to break here and be alert that this is a study for patients who are highly selected and they are with excellent prognosis even without radiation. Thank you.
Okay, thank you, Mushabbab. Hanadi, you want to comment on the question?
Maybe we can take more comments because for sake of time.
Okay, so write it down. Wamid, if you can start. Wamid is a well-known medical physicist. I think everybody know Wamid. تفضل يا وميد.
أنا مجليان, right? Thank you, Dr. Hanadi, for this excellent presentation. I just wanted to bring the issue, like probably Dr. Asiri alluded to it, the logistical things. Now, with when we do, we treat, for example, in the department about 400 cases of breast. So if we're going to change the practice in the future, probably this means that the load of patients on the department is going to increase, because now for every breast patient, we can accommodate another 2 or 3. So I think, because there was a conclusion that this is economically, it's economical way of treatment. That's true for the patient, but now the department has to prepare itself to have probably another CT. You won't need an extra machines, but probably you're going to scan more patients. You need more staff. You need a radiation oncologist, probably to accommodate this increase, and you need the physicists also for more, or dosimetrists for more plans. So I would just like to bring this issue, although it's not relevant now. This is, if you want to change your practice, probably in 5 years, you have to think ahead in your department how to accommodate this change of practice, because probably you're going to end up with more patients. Thank you.
Okay.
I thought in a different way. I thought like by using and changing this fractionation and changing practice, the load will be less on the machine, and we will treat, more patients maybe, but definitely the load will be less.
Maybe less on the therapist, but more on the medical physics, because the plan will be
your CTs, you're going to CT more, and you will have more plans. So you need a physician. You probably need more physicians. You need more physicists, and maybe you will end up needing another CT to accommodate the increase in your patient load. But the machines, probably not.
Zaid, if you want to start.
Yes, thank you, Hanadi, for your good presentation and nice presentation. My question, actually, I saw your criteria, but you didn't mention anything about the breast size. So what is your comment on this?
It
Do you
wasn't
feel like unsafe to treat a bigger breast with this regimen, or you feel comfortable?
No, they actually in the study, they didn't mention or comment about the separation, if you mean the separation, and the toxicity.
Yes.
And I believe, as the Prof. Yasser mentioned earlier, it was mentioned in the previous studies because the technique was different. So there was like more hotspot that caused more toxicities. But using field in field and changing in the technique, that really improved the outcome and the toxicity. I will not make it in one of the criteria, to be honest.
Sure. Just a follow up on this, and it's related to the first question of Mushabbab. The Mushabbab highlighted something very important indirectly. The difference between 26 and 27 gray, the two hypofractionation arm, is less than 5%, is only 1 gray. It did not make a difference in the local control, but it made a difference in the late toxicity, as Hanadi mentioned, because it happens, as she mentioned, we are in the steep part of the curve for the late toxicity, with very minimum change, made a big difference in late side effect. This is why the criteria of dosimetry that she mentioned should be really followed strictly. I mean, because if you a little bit loose on that, you are in the steep part of the curve where the study showed there is increased late side effect for that. Huda, if you want to ask your question.
Yes, Prof, thank you. And thank you, Hanadi. I had two questions, actually. The first one is, did they mention anything about the breast boost? Because I was just wondering, the standard arm, the 14-15, I'm sure some of them had a breast boost, but what about the fractionated arms? Are we gonna disregard the boost from now on, what do you think about that? And also, maybe I missed that in the beginning, but what is the regimen for the treatment? Is it daily 5 fractions, or every other day, or weekly? I missed that probably. Thank you.
Thank you, Huda. So for the boost, boost was allowed in the study. 25% of patients from different arms received a boost to the tumor bed. And the dose was ranged from 10 gray to 16 gray, and it was center-based, depend on the center. But the fractionation was 2 gray per fraction. The most common dose was used 10 gray and 5 fractions. Like 80% of the all patients who received those received 10 gray and 5 fractions. And for the 5 fractions, yes, it's in the daily basis.
Okay, so so what we would do if we're gonna adapt this is that we're gonna give 5 fractions for the whole breast and then another 5 fractions for the boost.
If you will give boost, right?
Okay. Okay. Thank you.
Okay, Dr. Saif, if you want to start your question.
Okay. Thank you thanks to the organizing committee for doing this. It's very humbling to see such scientific discussions going on. I just wanted to ask a quick question and also see the comments of the group about the competing cohort, which is patients who can get ABPI, especially now that we have the Florence trial. I personally have been doing for patients with very similar characteristics, the 30 gray and 5 fractions IMRT ABPI. In these patients, we don't necessarily worry about the boost, which is an additional added bonus in my view. And also we have 10-year data, which is the Italian data. So, I just wanted to know, what does the group feel, or what is your comments about overlap between, patients who might be eligible for the fast forward versus those who might be eligible for ABPI, especially the Florence trial, because the RTOG is very an inconvenient BID regimen.
Okay, Hanadi, you got the question?
Not really, بس يعني ممكن أي حد تاني يجاوب.
هو كان سيف هو كان عشان your voice was not very clear. I think Saif, he was referring to the partial breast irradiation. Now you said this low risk patient that you selected in your last slides is very much similar to the criteria of partial breast irradiation, which is also 1 week treatment. So he's asking you treat on this, or you have that trial which is published, 10 years follow-up, clear data, don't worry about late side effect. Why don't you treat them with partial breast irradiation? If I understood the question correctly, Seth.
It's more like trying to understand what the group is leaning towards in terms of doing specifically the Florence trial, the ABPI 30 grain 5 fractions partial breast, which can be done again once a day over 1 week, versus now that we have this, the FAST trial regimen.
And that's true. And if you want to move really and to change practice, the 5 fractions or the 1 week regimen, and I believe we don't have to select specific criteria. To be honest, I put this slide not because I believe on it, because I want to follow this criteria, but maybe I just feel more comfortable and safe to follow this criteria. But if the whole group will go and treat and we say that we're going to follow whatever in the trial, because trial didn't specify any receptors status or other like adjuvant or neoadjuvant chemotherapy. They just agreed and put them as like in the inclusion criteria. So if we want to really choose this good prognostic, it's better to treat partial breast and whole breast. But I have question for other like radiation oncologists who already started to treat and they changed already practice and they started to treat with fast forward about their experience, and if they are they noticed any like acute side effects more than the standard regimen. I believe Dr. Adnan and Dr. Majid, they already started.
Yeah. Let me, Hanadi, let me just finish because there are some people in the queue, and then we'll come to your question, which is, I think, is the most important one. Hayat, Dr. Hayat, if you want to start.
Yeah, thanks very much. So my name is Khizar Hayat. I work at King Faisal Specialist Hospital for the last 2 years, and previously worked in UK for quite a while. So I think it's practice-changing trial, and the discussion we are having is, should we extrapolate the data and use it in our population? Because certainly in KSA, we deal with a lot of our patients are high risk, and we are going to be having a very small group of patients who will fit into this criteria. So I think, as generally happens, maybe we should adopt the inclusion criteria of FAST-4 trial to start with. But I'm just throwing this to the panel that perhaps this is the need for KSA radiotherapy community to perhaps come up with a trial which would then answer the question of our high-risk patient, which at the moment we don't know the answer to. So I believe after this discussion of this, maybe there is a need to set up our own trial to deal with our group of patients. But certainly it's a practice-changing data. And final comments are about the late effects. I know we use new techniques and the hard dose is not much, but we know that the cardiac toxicity is come up even after 10 years and in 15 and 20 years. So we really have to watch the late effects. I think the local control is similar. Late effect is still a potential issue. Thanks very much.
Okay, thank you so much, Hayat. Yeah, definitely our category of patient is much higher risk than the Western community. Dr. Nadeem.
Thank you. Thank you very much, Prof, for giving me. Yeah, thank you very much for giving me opportunity to talk. So that's few short comments. Number one is that for fast forward trial, this tumor group size was only 1.6 centimeter median size, and they were all good group of patients, ER/PR positive, mostly HER2 negative, with small tumor, older age group. So we need to keep this in our mind when we do the apply this regime to our patient. This is to a selected group of patients, and you mentioned that in your criteria, the slide which is showing now. So we need to be careful. At KFMC, we actually utilize that for more than 50 years with tumor less than 3 centimeter, node negative, grade 1, grade 2, as you mentioned here. Also, just one update, one of the co-investigators shared with me yesterday only that they paused that trial, the subset of the trial, which was dealing with the node treatment as well, with 26 and 5. So that's one thing, cautious for the people when it is node positive, not to use it unless the part of the trial is completed. The second thing is about this, that 50 grain 25 fraction should not be used. I would disagree with that. There will still be selected group of patients. For example, larger volume, Canadian trial have shown that, the separation issue, and then Scandinavian shows that if your volume of the CTV for the breast is larger, more than 600, they say, but there are different, people have the cutoff, then you should use the 2 gray per fraction rather than 14, 15. And third, very quick comment is about the partial breast irradiation. So there are two issues in partial breast radiation, the dose and the volume. So basically, the regime, the accelerated regime. So I was co-investigator in the rapid trial in Canada and the RTOG study 0143. And they both published, and unfortunately, now they're showing that 1% less outcome than the, the whole breast radiation. So it's only 1% difference. But Florence trial did not show any difference, as was mentioned before. The other issue is that the dose of the UK low import trial, where they use 40 gray and 15 fraction to the same partial breast volume, and they have the equivalent outcome. So I think the doses used in RTOG and rapid trial was a bit higher than Florence, and therefore Florence was good, or 14, 15 was good in UK low import trial. So I still think that Astro have set up the guidelines. The patient more than 50 year and early stage breast cancer, or if the breast volume is too big and you have to treat it small, you can still utilize this partial breast irradiation. Question will be which dose is the best. To me, UK low import trial for 15 session or Florence trial, they both are good. Just, these are my few comments.
Okay, thank you so much, Nadeem. I think it's an excellent points and comments. You just remind me that in the fast trial, not the fast forward, the arm which is 30 in 5 fraction once a week, it showed higher late side effect as compared with the 28 once weekly. Hatim Marzougi.
Yeah, thank you, Hanadi, very much for the nice presentation. My question is about the 26, the hypofractionation study, this one. Now we all see in clinics patients who fits the criteria, but some of us, I think, still hesitant to proceed with this fractionation, despite that the patient have all the criteria that was mentioned eligible in the trial. So my question is, do you think it's the same story when we switch from 50 and 25, the standard fractionation, to 14, 15, which took lots of physicians sometimes to adopt this as a standard of care for them, as now we rarely see 15, 25. So do you think it's just like a matter of time for people to get used to it, or is the concern is mainly the short term follow-up, which is only 5 years, or they're worried about side effects or local control?
I know I really believe in this study, the fast forward, and I like it. Maybe because I presented twice, but anyway, I think it's a matter of time. If you remember, all the physicians took time to move to treat local regional with 40 and 15, and now we can just do it. Maybe after 10 years, after we get the result, the physician will be more comfortable to choose this fractionation and treat the patient with 5 fractions only. But that's what I believe, and I don't know really. I really would like to hear from other doctors.
Okay, I have here a doctor, sorry, just a username. It's written Ala Muhammad or something. If you can start the question. I apologize if I said the name wrongly. Okay. Yeah, go ahead. There is someone raising the... Okay, Hanadi, so basically it looks like you are pushing forward and really encouraging people to use this trial. As any new big change like this, people are a little bit reluctant, especially the late side effect. It's only 5 years follow-up trial. Although you mentioned in the trials before, like START trial, there was no difference between the 5 years. I mean, the difference between the two arms was not significant or was not changed after 10 years follow-up. So most likely the 10 years follow-up of this trial will be the same.
Yeah, I don't think.
Yeah, go ahead. Majid, Dr. Majid, if you want to have a comment, Majid Al-Uthman.
Thank you so much for this excellent presentation, Dr. Hanadi, and excellent discussion. My only remark is that around mid-March or April, we had the quarantine of Qatif area, and I lost 50% of my therapists, and I ended up with only 3 therapists with the load that I have. And so this came as a lifesaver. And Mukrahun Akhaka la Batal, we started the 26/5, me and Dr. Adnan Al-Habshi. And our experience over the last 6 months is that it is very well tolerable and very minimal side effects. Of course, we are treating only intact breast, no nodal or chest wall treatment. As you know, this trial in its original inclusion criteria included up to T3 and up to N3, but what we see that was published in May 2020 in Lancet is only the subset of patients with intact breast and no nodal, no chest wall, and no implant. Also, they included patients post-reconstruction. But we did not, we will see this properly in a future publication. Bottom line, I thought, and Dr. Adnan agrees that this is scary when you look at it, but when you see the patients and how well they do, most of them, they did well. I know it's been only 6 months with us, but we stuck with it actually. We liked it, patients liked it, and we continue to use it. And hopefully with longer follow-up and seeing more other scenarios such as post-mastectomy and post-reconstruction and nodal irradiation, we'll learn more. But for the time being, our practice for all intact invasive NDCIS is to treat with 26/5.
Even for NDCIS?
Yes.
Okay, thank
for
you
convenience.
So much. Yeah, go ahead, man.
Thank you, Dr. Majid.
Yeah, we treat. Yes.
Just a quick question for you, Dr. Majid. And what about the criteria? You said like your own institution criteria that you follow?
Actually, if you look in the original protocol, which is about 90 pages of fast forward, they had no criteria, to separate. It just happened for this subset that it's showing more favorable patients. As you know, they excluded from this published subset all the node positive, etc. But if you look at the original inclusion criteria, it included advanced cases. They just did not publish it yet. So for the time being, we treat all comers with node negative and post-lumpectomy with this regimen.
Thank you.
Okay, Dr. Ibrahim Al-Umari. Ibrahim.
Yeah. Yes.
Yes, go ahead.
Thank you so much, Hanadi, for this excellent presentation, and thanks, SARO, for this. Actually, as Majid said, actually he's the one who, put me in the guidance of this trial. He mentioned this in one of our talks, and I went through the 90-page of amendment and the original protocol, saw the article, and then I started. I actually treated a few patients with post-mastectomy chest wall who had complete pathological response post-neoadjuvant chemotherapy, as well as intact breast. And all, as Majid said, all the patients that I've treated, like the protocol, had no problems. Now I have the 3 months follow-up with the patient that they started treating in like May and June, and all of them are having the exact same, finding that you see with 40 and 15 and previously 50 and 25. So I think really we are a little bit skeptical about starting this because of the big change in the number of fractionation and the high dose per fraction. But if you start this, you can't go back. Really, it's just so easy, so quick, and our therapist likes it. Our dosimetry scientist likes it. It's easy to plan, and I think I encourage everyone to give it a try. Thank you.
Thank you so much, Ibrahim, for sharing this experience. Actually, this question Hanadi was asking, because it happens 1 or 2 patients that we treated, my colleague treated them in our department, they had more kind of acute toxicity, but we never know. Maybe these patients, even if they had the standard fractionation, they would have had the same high toxicity. It's not like a randomized trial. You cannot make a comment on one patient. We are getting close to the end of this. If somebody had any more question or discussion about this before I hand the microphone to Hussam or Majid to conclude or to comment.
Yasser, if you want to comment on the pool results, can you see it?
No, actually.
There is an icon down there, pooling.
I can't.
You mean the result of the survey,
Yes.
Hussam?
Yes.
Go ahead, Hussam. Go ahead, Hussam. Present it to us.
So we asked 2 questions. What is the percentage of breast patients receiving 50 and 25 fractions in your institute? And only 1 person answered. It's a 35 response we got, and only 1 person said 100%. And no patient treated, 0% is about 34%. I mean, about 1/3 of the responses, they said they don't use 50 gray in their institute. 11%, they are half of their patients, they are saying they're treated with 50 gray, and less than 10%, it's about 51%. It's about half of the responses. They are saying they are treating less than 10% of their patients with 2 gray per fractions. And we asked the second question, did you use 5 fractions adjuvant breast radiotherapy last few months? About 46% they said yes, and 54% they said no. So half of responses, I think they give it this try, and as everyone heard from Hanadi, I'm not sure because it's COVID-19 or, but as we heard from Majid, it's because COVID-19. But is it because COVID-19 or because it's convincing publication?
Okay, excellent. So it seems people they already use. I think it's a COVID-19 because I personally feel. I mean, they were very much pushed to use it. But it's great that 40% of the participants already treated some patient with this short fractionation. This is really unexpected result. Majid Al-Ghamdi, if you want to comment.
Yeah, thank you, bro. It was very interesting. Thank you, Dr. Hanadi. Just quick comments. I think, yes, people are not, they don't have time to publish commentary on this study and to critique it. And they're happy with it for the time being and to deal with the flow. And then you will see more of the commentaries later on published. But now I didn't see that many of documents that people replied to the authors of the study for some reason. But we will see in the next few months. But anyways, I think for myself, after all of this discussion, very interesting discussion, is that I'm happy to adopt this for the early breast disease after lumpectomy with no lymph node treatment. But I'm not happy to to entertain anything of any regimen of partial breast irradiation, and this was mentioned by Dr. Nadim and also Dr. Saif al-Jabab. As Florence study and all these things, there are partial and rapid study, there are partial, accelerated, some of them. But I think if you treat with hypofractionation the whole breast, I think it's safe based on this data, and we'll have to wait the long-term follow-up data. But the problem was always with probably the acceleration or the partial breast. When you accelerate, like in rapid study, they accelerated the treatment, and with hypofractionation and partial breast irradiation, and they had some more kind of cosmesis issue. And so I think it's more like when you treat the whole breast with hypofractionation, you're okay, but not partial breast or acceleration. Thank you.
Okay, Hanadi, do you have final comment?
Actually, I have a question.
Okay, further.
I want to ask my colleague if they had any or faced any challenges to meet the organ at risk, criteria. And if it happened, they change the fractionation and go back to the 40 and 15, or they are really restricted to what in the study.
So basically, Hanadi, she's asking if you did the dosimetry and it's not exactly as the study, the criteria, it's a little bit off. So you change your mind and make it 14, or you just go ahead? That's a question. So
I will say, yeah, I will say my take from the cases that we have done over the last 6 months, we had not met. Of course, we followed the strict criteria mentioned in the lengthy protocol, because, and there are not many, by the way. So it was easy to meet. So yeah, that's the answer. We did not encounter such a scenario.
Thank you.
Okay,
Thank you so much.
Yes, go ahead, Hanadi.
Yeah, no, I'm just thanking everyone for attending interaction.
There is one last thing. So I think I'm thinking about to adopt something related to our patients. SARO, it might be in a good platform or good place to start a multi-center study in metastatic setting. In ASCO this year, 2020, there was an abstract about doing mastectomies in metastatic setting. And they found, for example, in triple negative disease, they have worse survival when you address the local disease. One of the thoughts that because we are delaying systemic therapy, I think the 5 fractions treatment will be a great opportunity to treat this kind of patients. And we will try to prove the concept of treating the primary disease, same as we prove in prostate cancer, for example. SARO, I think, will think about initiating a SARO research group, and each center can apply for IRB for this. I spoke for some of the people there treating breast in some of the centers, and who's interested to be part of this research group, please contact me. Just I want to say that to initiate and start something applicable for our patients. Unfortunately, we have too many metastatic patients.
Well, it's a great suggestion. I think to open the subject of having collaborative research between the different institutions, I think it's a great idea. Definitely, our center will be willing to participate. Okay, I think for this session, I think we're coming to the conclusion of this meeting. I would like to thank you all for your active participation, and thank Hanadi for the excellent presentation. And we thank all the team in the scientific committee of SARO rounds. I think it's a very strong and excellent start. And we look forward for this monthly meeting. And as Majid mentioned, please feel free to share your comment and suggestion for the next meeting, if you want the format to be different, or if you have any other suggestion. Okay, Majid Al-Ghamdi, if you want to conclude this meeting.
Yeah, thank you, Prof, and everybody who attended this. It was excellent. We had like 66 attendees. This is when I was talking with Hussam, we thought that if we had like 10 attendees, it would be a success. But now we are exceeding this number. So this was huge success and huge push forward. Next Wednesday, next month, first Wednesday, we will have our next meeting, and we welcome all the suggestions by any means, to me, to scientific committee, to Dr. Hussam and our staff, anybody, as Prof said. Thank you very much.
Okay, thank you. We'll see you next month, inshallah.
Thank you.
Thank you.